So some of the objectives for the talk today, we're going to review the types of head and neck cancers and the locations of where those are. We'll describe the possible risk factors for head and neck cancer and the types of treatments that are available, as well as potential side effects of treatments and implications for survivorship. So it's estimated that there'll be over 66,000 new cases of head and neck cancer this year, and that accounts for about 4% of new cancers in the United States. There are several different risk factors for head and neck cancer. One could be alcohol and tobacco use. A second one is HPV, or human papillomavirus. And that's a risk factor for a certain type of head and neck cancer that involves the oral pharyngeal area, and we'll talk about that in a little bit. There's another virus called Epstein-Barr virus, which is the virus that is responsible for mono, is kind of what we typically refer to it as. And that's a risk factor for nasopharyngeal cancer, which is another location of head and neck cancer. Other risk factors could be gender, so men are 2 to 3 times more likely than women to develop head and neck cancer. Age, so typically head and neck cancers happen in people that are over the age of 40 and possibly with poor dental hygiene. But oftentimes we don't know, or most of the time we don't know why somebody gets a cancer and other people might not. And patients with head and neck cancers are at risk for developing a secondary primary cancer that would typically be in the lung or the esophagus, and those are due to similar risk factors, being maybe tobacco use or alcohol use. So there's several different types of head and neck cancer, and they can be treated very differently. This is a diagram or kind of a picture depicting all of these locations. So there could be cancers of the oral cavity or the lip. And then the bulk of the cancers we see kind of are in the pharynx area. So the nasopharynx is this portion back behind the nose. The oropharynx includes the base of the tongue and the tonsils. And then the hypopharynx is kind of further down here. The larynx is the voice box. And then there's also can be areas of concern either in the paranasal sinuses or in the salivary gland. And the salivary glands can be in multiple different locations. The most common type of head and neck cancer occurs in the oropharynx, and that encompasses 70% of head and neck cancers. So kind of looking back in that, this is this oral pharynx, so it includes this base of tongue and tonsil area. And for this location of cancer, one of the potential risk factors is HPV, which is human papillomavirus. And we depict whether patients have HPV positive cancers or HPV negative cancers. And that tells us just a little bit about their cancer in general. So HPV negative cancers, the risk factor for those are typically more tobacco or alcohol use. The incidence of this is decreasing. They tend to be in patients that are a little bit older. And these patients are the patients that might have a risk for more of a secondary malignancy due to those common risk factors. HPV positive cancers are cancers that we think are related to human papillomavirus. There's several different types of HPV. The most common type that we see that can cause this cancer is type 16. So that's the one that we typically evaluate for primarily. The incidence of this is increasing. Patients tend to be a little bit younger in age, and there is some evidence that patients will have improved response to treatment and improved survival. So again, there's several other kinds of head and neck cancer. So cancers of the nasopharynx, which is back behind the nose, is fairly rare, and it can be associated with Epstein-Barr virus, which again is that monovirus. Cancer of the larynx, which is, these are kind of just different locations, supraglottis, glottis, and subglottis. these are typically affecting the voice box. And so oftentimes these cancers are found fairly early because patients present with a hoarseness, a change in their voice, which is, something that would be evaluated pretty quickly. Paranasal sinus cancers are rare, and there's many different types of histologic subtypes, so different types of cells that can be causing those, and they're treated differently dependent on that. And then salivary gland cancers can be very different. So these can arise from a major salivary gland. That could be the parotid, submandibular, or sublingual glands. And then there's also several minor salivary glands as well. These can have multiple different cell types. And sometimes they do have a driver mutation, a driver marker, which we can target with treatment. And the most common ones for that is either an androgen receptor or a HER2 receptor, which is historically seen in breast cancer, but we can see that in salivary cancers as well. Staging with head and neck cancer, and really all cancer in general, is based on a TNM staging system. So that's the primary tumor is the T, and that tells us, how large the tumor is, maybe how invasive it is. N is lymph nodes, so whether there's any additional lymph nodes that may be involved. And M is metastasis, so if there's any traveling of the cancer to somewhere else in the body. The difference with head and neck cancer is that we do also use HPV status for those patients that have oral pharyngeal cancer. So if they're positive for HPV, that might give them a downstage a little bit. In general, early stage cancers are typically small with no lymph node involvement, and they typically receive surgery or radiation. Later stage cancers tend to be a little bit larger and may have lymph node involvement, and these patients tend to receive really any combination of treatment. Might be surgery, might be radiation with chemotherapy, or just chemotherapy alone. So the medical team will help to decide what's the best treatment plan, and again, that's based on staging and also the fit of the patient. So there's several modalities of treatment. One thing that can be done for head and neck cancers could be surgery. And surgeries for head and neck cancers tend to be very complex. So it's important to have a really good conversation with the surgical team, the surgeon, to find out what the expectations are after surgery in terms of, curative treatment for their cancer, and also what are the risks after surgery in terms of morbidity, what are the potential side effects of that and long-term effects. The ability to perform surgery depends on the extent of disease, so again, the stage, the fit of the patient, and the expertise of the surgical team. So these patients typically need to have a multidisciplinary team, which may include the surgeon, but also speech therapy, physical therapy, occupational therapy, so several different types of team members to help with getting patients through surgery. Radiation is a very common treatment for patients with head and neck cancer. And there's really two different types of radiation treatment that we typically use here. One is photon radiation, and the other one is proton radiation. So with photon radiation, photon is the most common type. We typically use a modality called intensity modulated radiation therapy. So essentially with photons, so photons are really a stronger version of the light beams from an X-ray. So X-rays that are used really for diagnostic purposes. It's the same type of energy. So it's a high energy X-ray that's pointed at a particular part of the body where the cancer is located. And through a series of interactions with these strong X-ray beams, they break down the DNA in the cancer cell and then render it unable to repair or to copy itself. So with that, it causes the cancer cells to die. With IMRT, again, this is kind of a modulated treatment of photon radiation. It allows radiation beams to be adjusted to the cancer more directly and less to normal structures, so it can intensify the dose to the cancer. And this is the predominant technique used in head and neck cancers. And compared to some of its counterparts or earlier type treatments, it's been found to improve xerostomia, which is dry mouth, in patients compared to more of a standard radiation. The other type of radiation that we do here is proton radiation. And with proton radiation, it's a similar modality of charged particles that's going directly to the tumor cells and killing the tumor cell, but it has less scatter to other areas around the tumor. It's more of kind of a direct effect to the cancer. This is a newer technology, so it does tend to be more expensive. The ability to target the tumor and deposit the dose directly to tumor is improved, compared to photon. And there's some evidence that there might be better outcomes with some types of cancer, like nasal cancers or paranasal sinus cancers. And the proton is used to treat the most challenging cases. So when it's thought that other radiation treatments may not be as beneficial. But the choice for radiation is really done on a case-by-case basis. We don't have enough data to say that proton therapy is superior to IMRT for the majority of patients. This is a graph that I thought was nice, just to show really what the photon beam of radiation is doing as opposed to a proton beam of radiation. As you can see with the photon beam, it's essentially traveling through the tumor, whereas with the proton beam, it's kind of stopping right at the tumor location and treating that more directly. With chemotherapy, there's many different kinds of chemotherapy that we use. One of the more common treatments for head and neck cancer is a combination of chemotherapy with radiation. And the chemotherapy helps to enhance the effective radiation. So that's why it's used in combination. Really, the gold standard for treatment is use of a medicine called cisplatin with radiation. And we use it either as a weekly treatment during radiation or sometimes as a higher dose. But that's kind of the gold standard when we're doing radiation and chemotherapy for curative intent treatment. There's induction chemotherapy, so if patients need to get chemotherapy right away to shrink down their cancer, they can have an induction chemotherapy, and again, that's given to shrink down the overall disease burden, typically prior to a patient starting a radiation regimen, and that might be radiation with chemotherapy again. And then we often use palliative chemotherapy, where the goal of that treatment is to control the cancer when a cure would not be an option. And there's many different types of chemotherapies that we use. Some of the potential side effects of chemotherapy are things like fatigue, lowering of good blood counts, which can cause an increased risk of infection, hearing changes, nausea, constipation or diarrhea, taste changes, kidney, liver abnormalities, hair loss, and peripheral neuropathy. And these can be helped manage with your medical team. So often, we schedule appointments frequently to discuss these potential side effects. Immune therapy is a treatment for head and neck cancer, and it is approved for palliative treatment, so in patients when a curative treatment may not be an option. The goal, again, is to control the cancer. And there are several different types of immune therapy that we use, nivolumab, pembrolizumab. The side effects with these immune therapies tend to be more mild compared to chemotherapy. And these side effects are immune mediated, meaning that they're autoimmune in nature. So with immune therapy, we're kind of harnessing the body's immune system to attack the cancer. And the side effect is that the immune system can get out of whack and cause some trouble somewhere in the body. And that's what these autoimmune side effects are that we monitor people for. And then there are several different targeted agents for head and neck cancer. Cetuximab is a targeted agent targeting the epidermal growth factor receptor. And by doing this, it helps to control the cancer. So this is used in combination with chemotherapy. It can be used in combination with radiation, and it can be used as a single agent by itself for patients with head and neck cancer as well. Side effects with cetuximab are a skin rash, diarrhea, and low magnesium levels, amongst other things, but these are by far the most common side effects that we see. Trastuzumab is a targeted agent targeting HER2. And again, HER2 was originally found with breast cancers, but that you can have a HER2 mutation in salivary gland cancers, and we can use trastuzumab for salivary gland cancers, either in combination with chemotherapy or as a single agent. Leuprolide is a gonadotropin releasing hormone. Typically, it's used more predominantly in prostate cancer, but for patients, some patients who have salivary gland cancers, they may have receptors which make them eligible to have leuprolide as a treatment. And then there's several clinical trials, and you know, the area of cancer research is really constantly changing and evolving as we're finding better ways to improve cancer treatments and also outcomes. The clinical trials may be available at any disease site, so any location of head and neck cancer and at any stage. So talk to your doctor about the availability of a clinical trial. There are several websites to look at. So clinicaltrials.gov is a government database which lists publicly and privately supported clinical trials. And then the National Library of Medicine at the NIH maintains that website. So it's really kept very up to date. And also through the Northwestern Medicine System, there is a way to look at available clinical trials, and that's through the nm.org website, and then there's a tab to click for clinical research. So there's several different implications for survivorship, and there's several different types or different potential side effects going through treatment. So one of the main side effects people have is mucositis, which is a painful inflammation in the mucous membrane. And again, it's the most common complication of head and neck cancer treatments. So pain needs to be managed during treatment to allow for comfort and also for adequate nutritional intake. So pain, again, kind of in the mouth and in the throat can affect people's ability to swallow and eat. And we want to make sure that they're maintaining their nutritional intake. There has been some evidence that good oral hygiene and oral care, including oral rinses and soft toothbrush, can assist with mucositis. We also have evidence of a use of a medicine called gabapentin, which can help with neuropathic pain, and that's associated with a reduced need for narcotic pain medicine. And often patients benefit from a referral to palliative medicine for assistance with difficult to treat pain as they're going through treatment and after as they're coming back off of their pain medicines. So nutritional status is important, and we monitor that regularly. It's monitored by our dietitians. All patients should be evaluated for nutritional status really at each visit. We try to avoid a prophylactic feeding tube for patients. The advantages of having a tube placed is that it can reduce the need for hospitalizations, in treatment-related weight loss, as well as improved quality of life, typically going through treatment. However, what we do know is that putting in a feeding tube does have some disadvantages up front. And so that would be as a longer dependency on the feeding tube and worse long-term functional outcomes compared to a more reactive approach, meaning like if patients are needing a feeding tube going through treatment, then we put the feeding tube in at that point. But there are several patients that we consider putting a prophylactic feeding tube in prior to starting perhaps a chemotherapy and radiation protocol. And those are patients that have a severe weight loss prior to treatment, patients who have ongoing dehydration, trouble swallowing, or pain interfering with their ability to eat or drink at the onset. Aspiration, which is ineffective when you swallow, that content going into the lungs and that creating a problem with infection. So if there's concern for aspiration, then we'll typically want to put in a feeding tube just to avoid that and risk of infection going through treatment. And it does depend a bit on the field of radiation. So if a patient has a large field of radiation, they may recommend that we put in a tube ahead of time. The referral to speech and swallow therapy is important for patients prior to starting treatment, during and after radiation treatment. It's important for patients to continue to maintain a good range of motion with the jaw muscles, and that helps to avoid trismus. Trismus is a restriction in the range of motion of the jaw, and that can affect people's ability to eat, ability to talk, and it could be painful as well. So the speech therapist helps by giving different kinds of exercises to patients to do, and we try and encourage them to do those during treatment and after, just to avoid this trismus effect. And then patients with feeding tubes should still be encouraged to intake orally if they're able to swallow safely. So as long as they've passed a swallow test and are able to do that, we want them to keep swallowing so that we can try and take that feeding tube out as soon as possible when they're finished treatment and in recovery. Lymphedema is the swelling or hardening of the neck, which is caused by the lymphatic system or a blockage of the lymphatic system due to either lymph nodes that are removed during surgery, or if they're damaged due to cancer treatment, like radiation treatment. So it commonly occurs in patients after the completion of treatment, and it's associated with increased symptoms. So like a negative cosmetic impact, sometimes even things like trouble breathing or poor mobility, ability to move the neck back and forth. Sometimes it can cause things like swallow dysfunction or even pain. So we refer patients to occupational therapy. Oftentimes they see them before they start treatment to have a baseline before they would start radiation, and then often after they complete radiation to have some rehabilitation. And patients learn different kinds of massaging techniques to help with decreasing that lymphatic fluid accumulation. And there are things like custom-made compression devices that can be used. So there's several different ways to help manage lymphedema, but that could be a long time consequence of going through treatment and those lymph nodes being destroyed. Dental concerns. So radiation to the head and neck area can cause dry mouth or xerostomia, and also salivary gland destruction, which can increase the risk for dental caries, dental infections, and an effect called osteonecrosis of the jaw. So patients should be monitored fairly closely with the dentist. There's several things that can be done to help prevent dental caries. Good oral hygiene is helpful, brushing twice a day, flossing daily, and using an alcohol-free mouth rinse twice a day. Decrease dry mouth, because dry mouth or xerostomia tends to be especially a long-term effect of going through radiation. And there are several different types of salivary substitutes, things to help stimulate salivary gland saliva production, and then also minimizing ingestion of things like alcohol and caffeine, because those can increase dry mouth. There is some recommendation also for use of fluoride, and so that's kind of why we send people to see their dentist for follow-ups every 4 to 6 months after completion of radiation, just to be keeping a good eye on what's going on in the mouth with the teeth. And then for patients who go through radiation treatment for head and neck cancer, they should be in touch with their radiation oncology team if they ever need to have any future extractions or surgeries. that may be in that radiated field, because they'll want to get clearance from the radiation team before they do that. Emotional concerns. So treatment for head and neck cancer is a very highly stressful situation, and the treatments can be debilitating. After completion of treatments, many patients can have what's called or kind of termed scanxiety, which is a anxiety relating to having follow-up scans, and that's pretty common for all cancer patients. They get more anxious, nervous around the time of when a scan would be due. With head and neck cancer, there can be some self-image concerns, so there can be changes with the body itself, ability to communicate, weight loss, feeding tubes, communication barriers, hearing loss. So those are all things that are important to address. And there is a high risk of depression for people going through cancer treatments. So it's important for us to be mindful of that and get patients into different kinds of either support groups or social workers that can kind of help with that. So what they found is that participation in a support group was found to be associated with better health related quality of life through decreasing depression, anxiety, and negative adjustment behaviors. So, so trying to kind of get patients into a community to be helpful is really important. There's many different types of late-term effects, and typically with time, these things do improve, but it can take a long time. So these are kind of some of the things that we see: pain, lymphedema, we talked about, a dry mouth, depression, again, is important to address that and talk about it. Abnormal thyroid function, so those are blood tests that are done either with the oncology team or with a primary care doctor after completion of radiation. Shoulder dysfunction, so some patients that go through radiation and especially surgery have some scarring of their shoulder muscles, or kind of a more difficult to manipulate the shoulder, that physical therapy can be helpful with. Physical therapy can be helpful with neuropathies as well. So that's like a numbness or tingling sensation in the fingers and toes. Sleep disturbance, speech problems. So again, these are all things that are possible long-term effects of treatment and things that may need to be followed up and managed. So in conclusion, head and neck cancers really have a pretty good outcome in general. So when we're able to do curative intent treatment, the survival tends to be pretty good. There is promise that the use of HPV vaccine will improve rates of HPV-related head and neck cancers in the future, which is encouraging. And in the coming years, research will look at continuing to have really good curative outcomes, but also to improve quality of life outcomes for patients, because I think that is incredibly important. And again, a head and neck cancer diagnosis can be isolating and daunting, but there are many resources available to help manage the side effects of treatment, whether those be acute for patients who are going through treatment or more long-term. So it's important to discuss these options with your medical team, and then also use community resources to assist through your journey, such as the social workers, a support group, or the Cancer Resource Center, such as Living Well.